Hello, this is Kent Hamilton speaking. We'd like to welcome you to today's webinar. We will be hearing from Deborah Bingham and from Amy Romano today. I'd like to make a short introduction of them. Amy Romano is a maternity care leader focused on care model innovation, patient and family engagement, and quality improvement. With a clinical background as a nurse midwife, Amy has spent her career working to improve maternity care and has particular expertise in primary prevention of cesarean birth, physiologic care practices in labor, midwife-led and collaborative care models, birth centers, shared decision-making, prenatal care service design, and health education. Amy was previously the project director for Childbirth Connections Transforming Maternity Care Partnership, a national multi-stakeholder initiative to improve maternity care quality and value in the United States. In this role, she consulted to the American College of Nurse Midwives, where she helped lead the development of the birth tools and reducing primary cesarean improvement toolkits. These tools have since been used to reduce cesarean rates in dozens of hospitals nationwide. Amy received her Master's of Science degree in nurse midwifery from the Yale School of Nursing and a Master's of Business Administration in Healthcare Leadership from the Yale School of Management. Deborah Bingham is founder and executive director of the Institute for Perinatal Quality Improvement. She is a public health leader, educator, author, and consultant. Deborah is also associate professor for healthcare quality and safety at the University of Maryland School of Nursing. Dr. Bingham has successfully led hospital, state, and national improvement efforts and held key leadership positions. She was Director of Maternal Child Health Nursing at St. Luke's and Roosevelt Hospitals in New York City, founding Executive Director of the California Maternal Quality Care Collaborative, and Vice President for Nursing, Research, Education, and Practice for the Association of Women's Health, Obstetric, and Neonatal Nurses. Dr. Bingham is a registered nurse with a Master's of Science degree in perinatal nursing from Columbia University and a doctorate in public health from the University of North Carolina, Chapel Hill. So at this point, I would like to turn it over to Dr. Bingham. If you have any questions during the course of the presentation, please enter those questions into the chat box. And toward the end of the presentations, we will answer those questions. Thanks for joining us.
Yeah, hi everyone. Nice to be with you today. Thank you for joining. And just want to point out that this session is being recorded. So just want to make sure everyone knows about that. But I'm really thrilled to have Amy Romano here with me. And we're very excited to tell you about the expanded intermittent auscultation education program that is being launched today. So Amy, I'm going to turn the time over to you now. Amy, I don't hear you speaking if you're talking. Yeah, you're muted. So let's get you. Can you unmute her?
I can't. She needs to unmute herself.
There we go.
Oh, yeah. Perfect. Thank you, Amy.
I apologize. Hi, everybody. This is our outline for today. We're going to go over intermittent auscultation from an evidence perspective first and look at how it can fit in to efforts to reduce cesarean rates in hospitals and nationally. And then we're going to show you our online simulation-based education program that launched earlier this year from PQI and that we recently expanded with additional simulation-based activities. And we'll have some time for questions and discussion at the end. Deborah, do you want to speak to the mission or?
Yeah, let me go ahead. Thank you. The mission of the Institute for Perinatal Quality Improvement is to expand the use of improvement science to eliminate preventable perinatal morbidity and mortality and end perinatal racial and ethnic disparities. These trends in the United States, the high rates of maternal deaths and the high rates of maternal morbidities, are very concerning to me and all of the other members of our advisory board for PQI. So that's why the Institute was formed, is to really, we know that QI saves lives. So we're really thrilled to have you join us, and everything we do is towards this mission. Next slide. Go ahead, Amy.
Great. So I wanted to begin by talking about the evidence basis for intermittent auscultation. And most of that evidence is in a Cochrane review that has been updated over the years, but really has not had any new additional randomized controlled trials added to it since 2006. But it's a large study, a systematic review of 13 trials that encompass over 37,000 participants in 7 countries. Those trials were published over a few decades from the 70s through 2006. And in most of those trials, the women and the people in labor had one-to-one care in active labor, and the births occurred in settings with low cesarean rates. So rates in the range of 5 to 10%, which of course is not indicative or representative of rates in our country. And you also have within this systematic review trials that were limited to low risk labor that was defined in various ways, but also trials that included intermittent auscultation versus continuous fetal monitoring for even high risk births or mixed risk populations. So within that, as the study designs and what encompasses the evidence, the outcomes were as follows. Really, for the majority of outcomes they looked at, there was no difference in intermittent auscultation versus continuous EFM as the routine for care. So in conditions including metabolic acidosis and perinatal death, which were the initial reasons for moving to continuous fetal monitoring in the first place. So no differences in those important outcomes, as well as cerebral palsy, as well as more kind of intermediate outcomes like NICU admissions and APGAR scores, or for that matter, analgesia and oxytocin augmentation for the labor. Some outcomes favored intermittent auscultation, and those include reduced risk of cesarean birth for fetal indications with intermittent auscultation, a reduction in instrumental vaginal births for fetal indications, and an overall increase in the spontaneous vaginal birth rate. And just one outcome in the systematic review favored continuous fetal monitoring, and that was neonatal seizure, but the effect size was small. So you would have to continuously monitor 667 people in labor to reduce by 1 the number of neonatal seizures. So this is the overall background. Obviously supports, as we see from all of the major organizations, at least the option, but really the favoring intermittent auscultation, at least for low risk births. But I do want to recognize that evidence comes from contexts that don't look a lot like what we have in the United States. Rates here, of course, are much higher, so we don't know from this body of evidence anyway that intermittent auscultation would reduce C-section rates, but it would be likely to because of a couple different mechanisms. The first is the low predictive value of continuous electronic fetal monitoring. So that means that you're going to have more false alarms, and you're going to need to intervene with operative delivery or other interventions to manage those findings when, as we all know, often even when a C-section is done for fetal indications, often the baby comes out and has good APGARs. So those generally would be false alarms, and you'll just simply have more of those with more screening, and particularly more screening in a low risk population. But we also know that electronic fetal monitoring fundamentally changes the labor experience, and in particular, it reduces mobility and autonomy. So that can really set up a cascade of interventions that can result in often in cesarean. And so what that looks like is continuous fetal monitoring being the routine of care and one of the first interventions applied upon getting to the hospital in labor, leads to reduced mobility, which can increase pain. And that's been shown in a number of studies that the ability to move around and assume different positions reduces the experience of pain. And then we see that that increased pain, and probably combined with that reduced mobility, can slow down labor progress just because of the mechanics and kind of how the pain and labor progress interact with one another. And then what that results in is the need for interventions like Pitocin or artificial rupture of membranes to speed labor, which increases the likelihood of fetal heart rate changes and substantiates the need for ongoing fetal monitoring. And all of that can kind of continue to cycle along into a very high-tech birth and often a C-section for either fetal indications or for slow labor progress. And so here you can just see, this is a typical looking birth with continuous fetal monitoring versus what's possible in birth environments that center intermittent auscultation as the routine of care for low risk labor. So Deborah, I'll pass it off to you to speak a little bit about efforts in the hospital setting.
Thank you. Yeah, we here at PQI, we do these PQI profiles, and you can find all of the profiles under the toolbar on our website. So you'll see the tools, and then you just scroll down and you look for PQI profiles. Anyway, one of the profiles we did was back in July 2019, was with Beth Hennessy, and she talked about reducing NTSB cesarean birth rates by implementing intermittent auscultation. This was one of the things they did out in California at her hospital there at Sutter Medical Center in Sacramento. Is they wanted to make sure they supported vaginal birth by having women have more freedom of movement. And so this was a quote from Beth where she says, you are considered a healthy low risk mom. We don't need to monitor you continuously. Actually, that increases your risk of C-section. So that was their approach to why they implemented intermittent auscultation at their center. And I know it's been a cornerstone strategy for a lot of other sites that have been working on reducing overuse of C-sections in their facilities because of the mechanisms that were outlined by Amy. So I'll go ahead, Amy, go ahead now. Amy, I can't hear you. Amy, you need to unmute yourself.
Sorry, each time I'm getting blocked and the host is needed, so sorry about that. These data show really what happens when continuous EFM is the standard of care nearly everywhere. You get a workforce that has been de-skilled in this skill, same as we've lost skills in other areas like breech delivery or labor support skills and so on. As people only have experience in hospitals with EFM, both the skill level and the confidence level with intermittent auscultation are reduced. So this was from a QI project that we actually did in a network of birth centers, which one would think would self-select for people who either have experience or comfort with intermittent auscultation, but we found that the majority of nurses and midwives had limited or even no experience in their training as well as in clinical practice. So, and what we also found through this QI initiative and others is that where people do have training and skills, they've been trained in different methods and have kind of different approaches and ways of communicating and standards for documentation and so on. So even where you see training, there's often a lot of variation in practice, which can cause challenges with efforts to have reliability and quality as well as patient safety. So when we go to either introduce intermittent auscultation or strengthen IA somewhere where it's been done unevenly, it's not just training people, it's a more complex initiative than that, but doable, and there's some good examples of effective QI initiatives with intermittent auscultation. But it generally starts with a written policy that addresses the key issues of who's eligible for intermittent auscultation, what's the frequency, how do you manage different IA findings, as well as what staffing levels are needed to support IA in that environment. Documentation standards need to be established, and EMR systems often need to be configured or looked at. And then obviously training and competency assessment, which we're going to talk a little bit more about shortly, so that everybody has the core IA concepts, the terminology, and the skill level. And then periodic review of performance in clinical cases can help with ongoing learning and continuous quality improvement. So many hospitals have implemented strip rounds and opportunities for people to look kind of retroactively at continuous fetal monitoring strips, but doing the same type of activity with documented intermittent auscultation can also provide opportunities for learning and thinking about both clinical management and best practice for documentation. So we wanted to run this poll, and I apologize that I don't know if I need to do something or hand it off to Kent, but this is the poll question that's going to come up. Before we show you the product, we're interested in gauging this group's interest, and you're not saying you will do something, we just want to know interest level, of a supportive Zoom-based program that would be multiple sessions long and that would train and coach you to implement an intermittent auscultation improvement initiative in your care setting. So Amanda or Kent, are you able to actually create the poll now?
Yeah, I can launch the poll right now.
Great. So if people can just take a moment and tap how interested you would be, and then at some point we'll have results. Amanda, do you have the ability to end it?
Yep.
Okay, go ahead.
71 people out of 80, so that's good.
That seems sufficient.
And then you could share the results, Amanda.
Great.
Yeah.
Okay. I know we've got self-selected and we put you on the spot, but that's helpful to know because we do feel that this training program that we're going to show you is really critical, but there are often just more steps and support that are needed to effectively change both practice as well as culture around measurement, around fetal assessment. So we'll keep in touch about opportunities that we may have for that coming up next year. I think, okay, great. So we're going to move in now and I'll show you what the product itself looks like. So we developed this based on an initial product that had been used in a birth center setting, and really thinking about how to develop an evidence-based program that is user-friendly and helps the learner grasp the concepts, and also can incorporate simulation so that people can practice the skills. So we developed it in this program, and this is what the product itself looks like once you are logged in, and you click right on the screen. It works on computers as well as mobile devices, although it's really optimized for a computer. And the program provides a mix of didactic education, starting with some of the evidence that I talked about earlier. And you can see along the left side, there is the different sections. So the first section is kind of a background of why IA and how it fits in with cesarean reduction and so on. And then performing and interpreting intermittent auscultation. So this is where the specific skills are taught, and as far as when to perform it, how to figure out eligibility and so on, how to listen and count. So you can see additional content here. And then, and throughout, as you can see, there are quiz questions. So you can see here, this is a quiz question related to how to listen and count. This program does teach the 6-second count method. So counting in intervals of 6 and multiplying each by 10. And so the learner would type 10 in this box here. Further on, there's some additional question types like this question on that comes later in the program on which of the following can be reliably assessed using intermittent auscultation. So in this, the correct answer to this question is the baseline rate. So you would click that. So that's the sort of first 2 sections of the program, and the learner can sort of self-pace through all of that. They can leave and come back, and their progress will be saved. And that section takes about 15 to 20 minutes. And then there's the simulation section, which has a number of simulation-based questions. And so it starts with a little scenario, which we're going to actually do now. So if people want to practice, we're going to watch one of these videos, but what the learner would do is have a pen as well as a timer or a clock. So if you want to take a moment and take out your phone timer or have a clock nearby with a second hand to count your 6-second counts, and then, you know, make sure your volume is up and so on. And so we would click play on this, which we'll go ahead and do, and you'll see just what one of these simulations. So if you can count, but you should be able to just audibly hear a pattern in this. So Amanda, I think you were gonna do this.
Yes, can you mute yourself while I get it
Yes.
ready?
Contraction is starting. Contraction is peaking. Contraction is going away. Contraction is completely gone.
Okay. Amanda, you can pause it there or just stop. The video does go on, but the learner is instructed to listen for just 30 seconds after the contraction goes away to get the rate. So I'm going to reshare my screen here in a moment.
Yeah, while Amy's doing that, I'll just say there, what we've done is we've now, what's being released today is the IA now has 5 simulations where they have this, you know, you go through an entire contraction with 5 different scenarios. So go ahead, Amy.
Yeah, and it's actually one sort of patient, and you're sort of managing it as you go as well. So different auscultations throughout her labor. But does anybody want to try in the box to message box to say what the baseline rate was? All right. Let's see. 140 is the correct answer. So I'm seeing some correct answers, some 130s, which, you know, there is some variation in there, but most folks got it right. The learner is able to kind of listen again, and you do get additional opportunities. They also become, we start with a simpler one where it's just about getting the baseline, and we kind of add on the ability to detect things like accelerations and decelerations. So you can see further on, after you just have to kind of learn the baseline, you actually need to provide baseline, determine whether an acceleration and deceleration were present. We also, the program teaches the terminology of category 1 and category 2, which is consistent with how A1 teaches intermittent auscultation. And for each of them, you also get a plan of care basics. And the program does discuss some of the ways that you would respond to a deceleration, including but not only putting somebody on a 20-minute strip or something like that. So the program also includes a downloadable practice guide. This is a sample, but the program itself, you can download it right out of there and print it and have it on the floor. So you have your full procedure, you've got all your definitions, as well as how to interpret and manage different results with a checklist for category 2 assessments. And this is just a nice quote. We've had the program adopted by lots of different folks, including the Frontier Nursing University. So Diana Jollis from Frontier said that intermittent auscultation, simulation-based education is wonderful. It should be part of all OB nursing, hospital OB, and midwifery programs. IA is such an important tool for normal birth, quality, and family-centered care. My experience has been that systems think it's easy and forget to orient and support professionals to learn the art and the science. This tool will definitely help close the gap. I'm so excited to see this. Thank you, PQI. And we're really pleased, and lots of Frontier students have gone through it. It does seem like it's picking up steam. So far, we've had over 450 learners since the beginning of the year when the program first became available. And really almost everybody says they felt that the program improved their readiness to safely perform intermittent auscultation. And we heard from a lot of people that they felt like it should be a standard training or something that's required for everyone, that it was easy to learn, and that even it was fun and enjoyable. And really the biggest piece of feedback that we got that was a consistent piece of developmental feedback was that people wanted additional case studies and practice. So that is why we decided to expand it. And it also increased the contact hours to a full hour. So Deborah, if you want to just go over how we use or how people can find it in the store.
Yeah, so first I want to let you know there are some frequently asked questions, and Amy, we do have in the chat, and I think it might be worth addressing at this point, because this is something that has come up before, is that using the term acceleration and deceleration for when typically I'll just read what she says in the chat. And you see it? Okay, go ahead and answer.
In case people aren't. So interesting that you use the term acceleration and deceleration when those are based on visual assessments. The way A1 teaches auscultation is to refer to increases or decreases, not accels or decels. This has come up again before. It's actually true that A1 teaches it a couple different ways. So there are materials from A1 that use increases and decreases, and others that do use the terminology of acceleration and deceleration for what are 15 beats per second above or below baseline for 15 seconds. So, and that is, so we use acceleration and deceleration in the program because there are others that have argued, and we agree, that using consistent terminology regardless of which method of assessment you're using is helpful for people to understand what they're dealing with. So the category 1 and category 2 are similar. They don't include the visual assessment components, so you can't use category 3, even if you hear something dismal. You need the visual assessment of EFM to look at either variability or sinusodal pattern. So we really did carefully check it against A1, and people have learned things certain ways and interpreted education programs differently. So we understand that this may come up against what people, ways people have learned it, but I guarantee you there's lots of different ways that people have learned it. And a lot of people feel very kind of uncomfortable when they have to use different language or find out there's different ways to learn this stuff.
Yeah, and we do quote A1 in the education. We quote ACNM and we quote ACOG because we want to be consistent with those, with their guidance, which we are, and also the principles and practices of fetal monitoring. So in that book, but there were some inconsistencies actually, and we did work with some A1 staff members as well. So just yeah. Anyway.
And there's another question here. So before we move on, why did we use the 6-second counting method rather than 5? And that is another thing that we felt, there's no one way, but it is important for people, for a unit, for instance, to have one way, and so sort of pick one or the other that is recommended. So that if you say I'm hearing 10s and 12, 10s and 11s, that means the same thing to the person, so that you can have clear communication. So we chose 6. It seems a little easier for most people to multiply by 10 than by 12. Yeah, and people have their preferences, I can see. And do we address the use of continuous electronic fetal monitoring ultrasound instead of Doppler? We find ourselves out of Dopplers so often. Yeah, we do recommend against using the EFM machine intermittently in this way for a number of reasons. It sort of isn't, the little bits of visual display that you're going to get are not sufficient to make a visual interpretation. There's some liability, reasons why it's not the best idea. So we recognize that happens frequently, and sometimes it can support mobility and give you the information you need. But ideally, you would have sufficient Dopplers. But
let me just add one thing. We do teach in the program how to do 5-second counting, but what we just felt, like Amy said, I'll just reiterate that a unit does need to have a specific approach, and so we followed our own advice, and throughout the program we just say we're using the 6-second approach, and so all of the exercises follow the 6-second. But there again, we don't try to say there's one or right or wrong way, just that your policy needs to be clear which way you all are doing it on your unit.
And there is a note about Maternity Neighborhood, which is an electronic medical record system. They do not provide category 1 and category 2 in the chart. I used to work for them, and actually we collaborated with them to do some upgrades to their intermittent auscultation charting. But where we used that, we would chart in progress notes throughout the labor of the category 1, category 2, and have at least the baseline and presence or absence of ACT cells and D cells with each auscultation.
And Amy, at the part, Rhonda also added something around when mentioning low risk patients, does this mean those without oxytocin or any pharmacological intervention, or is it determined by the hospital?
That would be determined by the hospital. I will say that, again, I think a lot of people assume all of the research comes from low risk birth, but there were in fact patients with Pitocin and epidurals and higher risk pregnancies, preterm labor and so on included in some of those trials. And we don't know for sure who, if anyone, fetal monitoring, continuous fetal monitoring is better for, but most hospitals would exclude people on Pitocin augmentation from having intermittent auscultation, but that would be something you would want in your unit policy.
Great. So yeah, keep the questions coming in. I'm going to go through a couple of things now, and then we'll have more time to answer the rest of the questions. We do have a list of frequently asked questions, answers to frequently asked questions on the website. It's already out there. Next slide. You just go to the tools bar, and that's also where you get the PQI profile, and you'll see IA education, FAQs, and then you can pull that up. We also then, you get the module, you get the intermittent auscultation module through the online modules section of the store. So you would just hit on the, on the menu bar, you hit the store button, and that will take you to that landing page I just showed you. When you're in the store, you click on the intermittent auscultation, and you'll see it's for 1 learner, 5 simulations. Make sure you sign in, because if you are a member of PQI, you get additional discount off of the list price. So you want to make sure you get that, that member discount. And there's 3 types of subscriptions or memberships available. The basic subscription does not, you do not get a discount because that's a free subscription. But if you are signed up for as a health professional, either RN, MD, midwife, or for PQI, then you would get, you would then go ahead and get, in addition to discount off the education, you would get these other services, which gives you action briefs, 2 action briefs a year, and other kinds of discounts off of any conferences that we offer. Premium, this would be if you wanted your whole facility to have a subscription, meaning that all of, then that's a group subscription, and so you could work with us on the group pricing for the intermittent auscultation program. So anyway, just wanted to point that out. You can see where to sign up for these subscriptions from the menu bar. Next slide. So now today, for a week, we're going to leave the special promo code is going to be also accessible. So if you decide you want to become a member, you would actually get the member discount. And also then you put in your promo code, you would get this 50% off. So, so then that is the best deal. So, but that will only be available until the 30th next week. You apply the promo code in the box that says apply promo code. You just put it, you type in the IA preview 50%. We are not advertising that promo code. It's only being, we're only providing it to those who took time out of your busy schedule to be with us today, or then listen to the recording. So, so you might want to write that down to be able to get that, to remember that. Again, it's IA preview 50%. Next slide. And just wanted to let you know about a couple of other resources and educational offerings that we have that would be maybe be of interest to you. And this, the Speak Up Against Racism program, which multiple states are also starting to offer throughout their states. We've been able to provide the training in Massachusetts, Rhode Island, Washington State is coming up in October and November, and Georgia we just completed. It's a QI approach to eliminating, dismantling racism in our perinatal care. And this is the acronym. There's more information about this program on the website. Next slide. And you can find, this is where you would go. It shows the store. It also shows the Speak Up landing page and the website address. The Speak Up program, we have an action pathway. We know that in order to dismantle racism, one and done is not going to happen. This is not the kind of a problem that you can fix with QI quickly. And so we have online modules as well for that program, as well as the live training. And I just wanted to point that out just in case you all, that's another problem you're working to solve. Yeah, we can, I just saw in the chat somebody wanted the promo code, and we'll chat that in so that you can have access to that. And this just shows where you go in. We have online education modules. IA is under the group of online education modules. Speak Up education and products are on its own group, and then PQI action briefs, which would are available. So PQI action briefs, these are members get access to this, or subscribers. If you're a paid subscriber, you can have access. You can buy these separately, but they're basically include a lot of information and examples. If you're implementing any of these types of QI projects, then these will provide you sample QI action planning tools as like completed fishbone diagrams, a driver diagram examples, and walk you through a case study with the slides that go along with it, so you could actually use those slides to help you make changes in your facilities. Next slide. And we use this case approach because I think that's a great way for people to learn QI, and again, gets back to our mission. Next slide. You will be seeing out on social media a flash sale for the intermittent auscultation. Again, the best deal will be for you to use the 50% promo code that we're giving you today. The flash sale is only like a 2-day flash sale, and that's for anyone who isn't here with us today or doesn't listen to the webinar. All right, next slide. Again, don't forget to put in your promo code. Here's the again, the promo code for the 50% off is IA Preview 50%. And just to remind you, if you want to get even a better deal, then you can become a member. All right, now let's go back to the chat and the questions that people have been chatting in. If you have any questions about how to access or any of this information, you go to info@perinatalqi.org. That email is available at any time for you to get more information. So do we have other questions coming in, Amy?
We've got one. Do we have anything that qualifies for NARM peer review training? And I am not familiar enough with what the requirements are there. This has contact hours for nursing CNEs. Certainly some of the tools and resources that PQI offers could be used in a peer review context for community birth providers. But if you, Aisha, if you want to put additional information in or get in touch, we can look into that.
Question came in about litigation. I know from personal experience when I was a director of nursing that we offered both intermittent auscultation as well as continuous for our more high-risk patients. It was actually easier to defend the intermittent auscultation. There's so much evidence to say that that it's evidence-based. There's no problem justifying the use of IA, and it's actually easier to defend and not have some witness, some expert come in and scrutinize hours and hours of a fetal monitor tracing. You do need to document, and we do provide you clear in the education, clear information about recommendations around documenting IA. But there is no problem defending IA cases in court. And I personally think it's actually easier having been through that. Okay, there's a question about Speak Up. It says, how do I speak up with my school diversity inclusion leader? And you took part, Barbara took part in part 1, and she thinks that this program could help Duke School of Nursing. Great question. We could talk about that offline, but basically the one place to begin would just be to have people access the online modules that I just pointed out. And also, yeah, go to the website and to the page that there's also the pledge, there's a video. We put quite a few free resources out on the web. On our website. So yeah, thanks for that question, and thanks Amanda for posting the information about Speak Up. But the in-person, the steps 1 through 3, as I showed you in that action pathway, are really, the in-person, we really help and coach people in how to create action plans. We really feel like this is bigger than, and you'll hear, although it includes information about implicit and explicit bias, it's bigger, the issues are bigger than that. And so we really get into dismantling racism in that program. Other questions for us today about the IA program or other PQI services? Oh, Rhonda says she's a Frontier student and I don't recall this being offered to us midwifery students. So was it temporarily access or was there a temporary code? Your instructors would be providing you with a promo code as a student. And we have student pricing for the intermittent auscultation. So I would go back to your instructors because we have had many Frontier students come through and access the education. So I'm not sure when they offer it to you in the curriculum, but it is something that is, I do know has been actively being offered. It's not free. The students do have to, but we do make it very affordable at a student price. Other questions? Amy, do you have anything else you want to add?
That's, am I off mute yet? Okay. No, sorry, it's been so awkward coming off mute, but it's been great. I appreciate everybody's questions and all the enthusiasm about this topic. And let us know if you have additional questions and reach out.
Well, great. Thank you, Nancy, for chatting, and thanks for coming, everybody. It's so fun seeing so many people I know on the chat and joining us as participants. I think, yeah, we're super excited. And I have to say, Amy's just, I mean, what she's put together as the lead author of this work, I'm just so proud to be a part of it. So thank you, Amy, for all of your hard work with this program and helping it get out there for people to improve auscultation. So intermittent auscultation. So thanks, everyone.
Thanks, everyone.
Yay.